Okay, so that's us live. Hi, everyone. I can see that there's a good number of people already here, but I'll give it until 2 minutes past 8 p.m. UK time, and then we can go ahead and start. So I'll just give it another 3 minutes. Right, okay, so I think we'll go ahead and start. So welcome everyone again to one of the Mind the Bleep Urology series sessions. Today's topic is going to be about flank pain and renal colic. So I'm going to go ahead and hand over just now to Dr. Hafiz, who's going to be talking about this subject.
Thank you, Dr. Zakaria. I'm Dr. Hafiz, and I'm working as an international training fellow in urology at University Hospital Birmingham. And as Dr. Zakaria said, today's our topic of presentation is flank pain and renal colic. It's a very broad topic, and I've tried to cover it as much as I could in 45 to 60 minutes. I will see how it goes. So, urological complaints with which patient presents, it could be characterized by either pain, and there could be any change in the act of micturition, and there could be some changes in the gross appearance of the urine, any change of function or appearance of male genitalia, or sometimes with systemic symptoms. Pain associated with any urinary tract abnormalities are either purely because of inflammation or infection. So what happens with inflammation and infection is that The capsulated organs like prostate, epididymis, and kidneys, whenever there is inflammation of these organs, the nerve supplies of the capsule, they are stimulated, and that's what causes pain. So what happens, the inflammation within a capsule, and as the organ is limited by the capsule, when it inflames and exerts pressure on the capsule of the organ, that causes pain. So pain is really inflammatory in origin, most of the urological abnormalities. Tumors, as they do not cause much inflammation, tumors don't tend to cause any pain unless it's there are in a very advanced stage. When the mass of the tumor is so enlarged that it exerts any pressure on the capsule, only at that stage the tumor causes pain. Flank pain is one of the most common E&E presentation, and I think most of you guys have seen a patient with a flank pain in E&E. Flank pain has a very broad differential diagnosis. The flank pain of urological origin is classically located in the ipsilateral costovertebral angle, just lateral the sacrospinal muscle and beneath the 12th rib. And patients have this classic sign of where they're holding their flank. It looks like they're holding their flank, and when they describe the pain of their flank, which is mostly urological in origin. The radiation of pain is usually around the upper abdomen, but it can radiate towards the umbilicus or the groin or the testes, and in females to the labrum. Causes of flank pain. From urological perspective, the most common cause of flank pain is renal or ureteric obstruction caused by renal or ureteric stone. If there is no obstruction, the stone could still be there and it would not cause any pain. There are lots of cases, I'm sure you guys have gone through, where there are stones in the kidneys and patients are asymptomatic and they are only found as incidental finding. So a stone itself doesn't cause any pain, and it's only the obstruction which happens when a stone causes blockage that it becomes a source of pain. And renal and ureteric obstruction caused by other pathologies like blood clots or papillary necrosis seen in diabetic patients, or obstruction caused by tumor of the upper tract, which we call transitional cell carcinoma, or congenital abnormalities like pelvic junction obstruction, or congenital or iatrogenic strictures, or any external compression by tumors or tuberculosis or any inflammatory process of the abdomen. All of these can lead to renal colic. As well as any inflammation or infection of the kidney could also present as renal colic or flank pain. Other rare causes of flank pain are trauma of the kidney, renal infarction, secondary to either trauma or thromboembolic processes, ureteric stents inserted for any cause, then patients with congenital abnormalities leading to vesicoureteric reflux, and other problems of upper tract. There are lots of non-urological causes where patients also present with flank pain, and it sometimes gets difficult to differentiate whether the pain is urological or non-urological in origin. This slide shows that common presenting quadrant of complaints of patients, like patients with gallstones, cholecystitis, stomach ulcer, renal ulcer, can have pain in right upper quadrant or in the central upper quadrant. Patients can have and can be presenting either with renal colic or appendicitis or inflammatory bowel disease or constipation or other sources of pain. In females, especially pelvic pathologies, they can mimic renal colic or flank pain, causes or pelvic inflammatory disease, triple pregnancy, ovarian cyst or torsion, and they all can mimic flank pain. Interestingly, the pain of renal origin is often associated with gastrointestinal symptoms as well. So that makes it a little more confusing to rule out pain of urological origin or whether it's in any intra-abdominal cause that's causing the pain. The reason that renal pain causes gastrointestinal symptoms is because of the common nerve supply, and it results in reflex stimulation of the celiac ganglion, as well as when there is severe inflammation of the kidney or the ureter, that can also irritate surrounding structures, and that could also lead to gastrointestinal symptoms. To differentiate pain, flank pain, whether it's a urological or non-urological cause, one of the most stark differences that you guys could appreciate would be that patients who have intraperitoneal pathology, the patients usually lie very still because any movement causes peritoneal irritation and that aggravates the pain. Whereas the pain that's of urological origin, patients are not able to sit still, they wriggle in pain, they walk around, they hold their flank and move from side to side. So that's one of the major differences between flank pain of intra-abdominal origin or urological origin. Then renal colic, any flank pain which is caused by a renal or ureteric cause is called renal colic. It's really very acute and it's caused, as we discussed earlier, due to obstruction. And the characteristic of the pain that patient describes is it's usually very sudden in onset and severe, and patients often describe it as a dull and aching pain. Some patients describe it as a sharp pain as well, but that's really more with a ureteric stone than with renal pains. The pain, as I described earlier, any organ that's bound with a capsule, when it distends, it causes pain. So any obstruction in the path of the urine from kidney at PUJ to VUJ, any obstruction at any level will result in distension of the capsule of the kidney. So that would be the pain in the flank. And the other source of the pain would be if there is any obstruction in the ureter and the ureter goes into hyperperistalsis to get over that obstruction, then that waves of pain felt would also be very severe. This classic renal colic is really seen in either stone or pyelonephritis or any clots or papillary necrosis. So any acute obstruction of the kidney or ureter could lead to renal colic. Pain can also sometimes indicate the location of the stone, as stone in various parts of the upper tract are radiates and present slightly differently sometimes. It's not always a rule, but it can sometimes help to see if the patient that is in renal colic, where the stone you could expect on further diagnostics. So upper ureteric obstruction, pain really radiates to the ipsilateral testicle or labium in females. So that's an interesting thing because upper ureter, you expect the pain to be a little higher, but actually the pain of the upper ureteric stones really are in the region of the groin and testicles. And that's because the testicles have the same nerve supply as the upper ureter. So from the L1. So that's why pain of the upper ureter, it radiates to the testicle or labium. The mid-ureteric obstruction, it's referred to the McBurney's point, and it's sometimes mimic appendicitis on the right side and diverticulitis on the left side. And then there is lower urethral obstruction, and it is when the stone is almost into the bladder, and what we refer to the vesico-uteric stones, and it produces lots of vesical irritability, and patients have associated symptoms of frequency, urgency, and suprapubic discomfort. And in men, it radiates to the tip of the penis and in urethra as well. The pathogenesis of stone formation, which is one of the most common cause of lung pain, is a very complex topic. And there are various theories to describe the process of how a stone is formed, but no single theory has achieved wider acceptance because of the things that they explain. They are not able to explain all the stone formations. They only explain part of the stone formation processes. So most common theories are nucleation theory and crystal inhibitor theory. So the nucleation theory suggests that stones originate from crystals or foreign bodies immersed in supersaturated urine. So the urine has to be supersaturated for the stone to form, and any crystals or ions that are in higher concentration, they aggregate and give us point of origin where other ions aggregate around them and they form a stone. So, but the thing that this theory can't explain is why patients get stone in one kidney and not the other kidney, and why some patients who have very supersaturated urine are still not make any stones. Then this is the theory of crystal inhibitor theory. It claims that stones actually form in the absence of inhibitors of stone formation, like magnesium sulfate, magnesium citrate, pyrophosphate, and other trace metals. But then again, there are patients who have low levels of these inhibitors and they still don't form stones. And in contrast, there are patients who have a very high level of these inhibitors and they still form stones. So these are contrasting claims that they're not able to explain completely what the cause is. Then there are around 2/3 of the patients who are able, we can find a metabolic cause in those patients of the stone formation, but then there are 1/3 of the patients who form stones, but there are no metabolic abnormalities in them. The stone composition, the most common stones are calcium oxalate stones, and the second common stones, hydroxyapatite, the brucite, and rare stones are mostly non-calcium containing stones, uric acid, stowite, cysteine, and other. Hypercalciuria, it's one of the most common cause of stone formation, and it's one of the most common abnormalities identified on metabolic workup of patients with stones. Hypercalciuria is really caused by 3 unique pathophysiological abnormalities. It's really described as type 1, type 2, and type 3. Type 1 is absorptive hypercalciuria, where there is inherent ability of the gut to increase calcium absorption from the gut, which leads to increased calcium excretion. There are 2 types of absorptive hypercalciuria, actually. One is where it's diet dependent, and the other is where it's diet independent. So the one where it's diet dependent is where restricting the calcium to less than 1 gram or 1,000 milligrams really helps with decreasing the incidence of stone formation. And only this small category of patients who require limiting their calcium intake, there is a wider myth in general population that anyone with a kidney stone should decrease their calcium intake. Then there's renal hypercalciuria due to the primary cause of renal leak of the calcium. And then the third, type 3, is due to resorptive hypercalciuria because of increased demineralization of the bones, which results in excessive calcium going into the kidney. Hyperoxaluria is the second cohort cause of getting calcium stones. Hyperoxaluria is an autosomal recessive disorder of glyoxylate metabolism. It leads to an increased saturation of calcium oxalate and subsequent formation of calcium oxalate stones. The rare cause is primarily where there is genetic abnormality and patients are not able to metabolize oxalate properly. The other is enteric, which is the most common one, and it happens in patients who have a smaller gut and have irritable bowel disease or inflammatory bowel syndromes, and they are not able to absorb enough calcium. So what happens is that whenever there is a decreased amount of calcium or increased amount of oxalate, so calcium and oxalate, it binds into the gut and becomes inabsorbable. But when there is an increased oxalate as compared to calcium, there is an increased absorption of oxalate, which results in hyperoxaluria. The other causes are Hyperuricasuria. It's again excessive dietary intake of purines. It's only 10% of the patients who form stones have high urinary uric acid abnormalities, and only 40% of the calcium stone formers have this abnormality. It's also aggravated by lower urinary volume and pH. Hypocitria, it's an inhibitor of renal stones. So the decrease of citrate in the urine, it aggravates stone formation in the patients. Citrate is an inhibitor of the stone formation. So most of the medicine that helps in the prophylaxis to prevent future formation of kidney stones have citrate in them. The stone varieties, we have discussed the stone metabolic abnormalities just briefly, and then there are some stone varieties that are important, like the calcium calculi. So they make up 80 to 85% of all urinary stones that we see. The causes of calcium calculi is varied. It includes increasing urinary calcium, increased uric acid, oxalate, and decreased citrate, which is an inhibitor. And again, there are 1/3 of the patients who don't have any metabolic abnormalities and they still form stones. So white stone is one of the most important stones from urological point of view, in that these have a very high mortality. Patients who have a staghorn stone of steroid origin has 50% mortality in 5 years if they are not treated. These stones are formed of magnesium, ammonium, and phosphate. They are one of those stones because they don't cause any obstruction, and they are painless and are often incidentally found in scanning patients for other causes, or patients scanned for the repeated urinary tract infections found to have steroid stones. These are stones that are formed by organisms like patients who have infection with Proteus, Pseudomonas, Providentia, Klebsiella, Staphylococcus, and Mycoplasma. Patients have a very high pH because these organisms split urea into ammonia. So patients have a very high pH of more than 7.19. Acetohydroxamine, which inhibits urease, but the problem is that it's not well tolerated and is not often recommended for the treatment. Most appropriate treatment for patients is complete clearance of stones and all its residue from the kidney, and then putting the patients on high fluid intake and sometimes on prophylactic antibiotics to prevent any urine infection. So this is a screw white stone. You can appreciate how you can define calluses of the kidney on this stone. Then uric acid stone, although they are very rare, but these are one of the stones that are not visible on X-ray, and it sometimes become difficult to offer some of the treatment modalities to these patients, which rely on X-ray technology. Again, these stones are formed when patients have acidic pH of less than 5.5. So the treatment is mainly aimed at increasing the urine output and increasing the pH for up above 6 or 6.5. One of the good things about these stones is that these can be dissolved without any intervention by just alkalinizing the urine. And it's estimated that around 1 centimeter per month of stone can be dissolved with appropriate therapy. These are some of the varieties of uric acid stone. So even the stone of the same composition can have different shapes and sizes. So you can't always describe which stone it is just by looking at it. Then these are some rare stones on cystine stones, and these are again due to metabolic abnormalities and the body. Cystinuria is again autosomal recessive abnormality, and genetic causes leads to these stones. These are rare stones. Xanthine stone, again caused by congenital deficiency of enzymes. Stones occur in patients, not all the patients are enzyme deficiency, but only 1/4 of the patients with this enzyme deficiency. Treatment again rely on high food intake and renal alkalization. So any patient who presents with flank pain, they undergo thorough history and examination. And the most important things to ask patients with a flank pain in regards to the history is any association of the pain with any other symptom, like are they having nausea, vomiting, or the patients having any associated abnormalities, like they have fever or other symptoms like pain aggravated by any physical activity. The thing about most commonly we face difficulty in patients who do not have any obvious cause of the pathology, like their imaging is all normal, their bloods are all normal, but they're still having flank pain. In those patients, very difficult to diagnose what the cause of the pain is, and they keep presenting again and again. The most common problem in those patients is really musculoskeletal pain, and musculoskeletal pain of the back, upper back pain is very hard to differentiate in between from renal colic, because they have quite similar presentation. The only thing missing is that you really don't have much of gastrointestinal symptoms, and the patients can often relate their pain with physical activity, that lifting or walking around that aggravates their pain. So if their pain is aggravated or have any association with physical activity and their bloods and other investigations are normal, then we can give them some muscle relaxants and analgesics and refer them to pain clinic or ortho. The most common investigations we do for any patient who present with a flank pain and suspected renal colic would be our baseline. The CBC, we need to know if how their hemoglobin is and what their white cell count is, if they're having any signs of increased inflammatory markers, raised white cell count. And then UNEs, we want to make sure that their creatinine is within normal and there's no drop in their EGFR, and the electrolytes are normal as well. CRP, again, we need to know if there is an inflammatory process going on and infection. INR, we need if we are planning for any intervention in these patients. Urine dip, I think, is one of the most useful and often overlooked investigation in assessing a patient with renal colic. And whenever I'm on emergency calls and have to see patients on E&E, discuss patients in E&E, the clotting doctors often forget to do urine dip, and this has a major problem with managing patients and defining whether this patient, because this is one of the earliest non-invasive tests that you can do to rule out whether the flank pain is from renal or non-renal in origin, like urological or non-urological. So patients with flank pain who do urine dip, they will either have infection, so there will be nitrites or leukocyte positives, or if they have stone, there would be hematuria, microscopic hematuria. So interestingly, 80% of the patients, 80 to 90% of the patients who have any renal or ureteric stones will show up with microscopic hematuria on their urine dip. And researchers have shown that only 10 to 20%, so only 10 to 20% patients of urological pain can present without microscopic hematuria. So it's a very good differentiating test to know the cause in early presentations of patients. And then we can do a urine culture to see for any infection if it's indicated by the urine tip, or if the patient have any symptoms. And then the imaging, which is ultrasound scan, CT/KUB, X-ray, IVU. Most commonly is the CT scan that we do to rule out any ureteric or kidney stones or any other urinary tract abnormalities. Then if we have a stone available from either spontaneous passage by the patient or from surgery, we can send it to laboratory for analysis to see what the cause of the stone is. So the most important investigation in urology, as I think most of you are aware of, is CT/KUB plane. And the good things about this imaging modality is that it does not need any IV contrast, it doesn't need any bowel preparation, and almost all stones are visualized. I think 99% of the stones are visualized by CT/KUB. They're very rare stones like Indinavir stone and some other drug stones that are not visible on CT/KUB, but that's very, very rare. And then again, you can assess the kidneys on the CT scan, and you can assess whether the stone height and hardness of the stone, which is a measure on the CT scan we call Hounsfield units. And this can help us to differentiate between what treatment modalities we can offer to the patient. I will discuss it later in the next slide. And so this is one of films from the CT/KUB where you can appreciate left pelvic ureteric stone, PUJ stone, and it's causing some distension in the calyceal system. If you could compare it with the other side, that's right side. So this is what helps us with giving patients treatment options. Like this patient, if he is not septic, he should have, if he's not septic and his renal functions are good, he can have lithotripsy treatment, which is an outpatient non-invasive treatment. If he is septic, he would need tube put in from the back, which is we call nephrostomy, or the other option is to stunt this patient. Other investigations are IVP or IVU, so intravenous pyelogram or intravenous urography in some countries. The good thing about this test is that it tells us the function as well as the anatomy of the kidneys, and it's better able to appreciate on this IVU the anatomy of the upper tracts, any filling defects on the tracts. The downside of this is that it requires a very skilled operator to take good IVU, and problems like inadequate bowel preparation, or if there is an ileus or lots of swallowed air, they could really affect the quality of the scans. This is an IVU, as you could appreciate. On the left side, there is normal kidneys and ureters, and you can appreciate the bladder as well. But on the left side, on the right side, you can see that there is marked hydronephrosis of the left kidney, and there is which you can appreciate a stone in the PUJ as well, and then there is no contrast going into the ureter on the left side. Other investigations that are usually done are no longer being done in developed countries like UK, and mostly being done in underdeveloped countries, or KUB films and directed ultrasonography, where we don't have the technology to do the CT scan for every patient. Their efficacy is almost comparable to IVP and sometimes CT scan. So the method of doing this is that you get an X-ray. The stone has to be visible on the X-ray, and then you do a directed ultrasonography to assess the kidney and the stone. It's very much operator dependent, and It doesn't give us as much anatomical details of the surrounding structures and the kidneys as we get from CT scan. Other investigations like retrograde pyelogram, MRI, and nuclear scintigraphy. The MRI is done usually in pregnant female where we want to avoid radiations, and nuclear scintigraphy is really done to appreciate the functions of the kidneys and to compare renal functions between the kidneys. So the most common treatment options we offer to patients who have small kidney or uretaric stones is observations. So any patient who has a stone of less than 5 millimeter have more than 50% chance of spontaneous passage within 6 weeks time. And once the stone size goes above 5 millimeter, the chances of it passing spontaneously decreases. Where here we have the med therapy, then, which is the medical expulsive therapy. It is where we give alpha blockers, usually a tamsulosin, and sometimes NSAIDs to help with the pain, and patients are able to pass stones. So med therapy, it's only indicated for patients who have a stone larger than 5 millimeter, because stones more than 5 millimeter, it hasn't shown to be of much help in those patients. And any stone that's more than 1 centimeter is would usually require some kind of intervention. So patients are not really able to pass stones more than 1 centimeter. So your med therapy is for the stones of sizes 5 millimeter and 1 centimeter. Any patient you offer conservative treatment or med therapy should be monitored for 6 weeks, and if they still have persistent symptoms and haven't passed the stones, then they definitely needs intervention. The stone site at the presentation also predicts the chances of passing stones. So lower uretaric stones, as you would guess, has more chances of spontaneous passage as compared to upper or mid uretaric stones. As we discussed earlier, uric acid stones and cystine stones are the stones that can be dissolved by alkalinizing the urine, or by either by oral or intrarenal methods. Intrarenal methods are no longer used, and it's really only the oral method that we use to dissolve these stones in asymptomatic patients. Steroid stones dissolution therapies have been tried with Sobeys resolution, hemiacidrin, but most often, given the size of the stone, it's mostly the intervention like percutaneous and peritoneal to completely remove the stone, and antibiotics to prevent the stone recurrence, which we offer as treatment modality. Most percutaneous nephrostomy is one of the procedure that we undertake in patients who have urosepsis and or may not be fit for any intervention in the general anesthesia. So it's mostly a temporary diversion to relieve the obstruction until the patient have a definite treatment for the cause of the obstruction. Urinary tract obstruction, which is often related to a pregnancy, the percutaneous nephrostomy is a good option as it's done in the local anesthesia. Then patients who have any infection or perinephric fluid collections or abscess or urinomas, and they tend to do better with nephrostomy. Again, in patients where we try to stent them to the Euroscopy or cystoscopy through the retrograde pathway and they fail, then we have the option of percutaneous nephrostomy to offer to them. It has the advantage of offering a tract to the upper tract where for future treatment of the problems. Like if a patient have a PUJ stone and we want to do a PCNL later on, if we do a nephrostomy, the PCNL, one step of the PCNL is already done, that's making the tract. So it helps with that. And then in cases of fistula or leaks or traumatic injuries, malignancy, inflammation, other causes that leads to obstruction of the upper tract, nephrostomy is a good option. Then this is one of the non-invasive treatment modality that we can offer to patients. It's any patient with an upper uretaric stone or renal stone, or in some cases lower uretaric stones offer this treatment modality. It's not suitable for mid-ureteric stones because of the ureter near the bones, but for the lower ureteric stones and upper ureteric stones, a good treatment modality. Patient has to be asymptomatic because we can't offer this treatment to septic patients, as when the stone fragments, there is risk of causing bacteremia in those patients. It's one of the non-invasive treatment modalities, but the downside is that some patients may not have the body habitus that's required for lithotripsy, or sometimes their weight is more than the weight limit of the table, and some patients may require more than one session to completely get rid of the stone. And one of the complications that tend to happen most commonly with slightly larger stones in patients with lithotripsy is that multiple fragments of the stones, once they go down, they get stuck in the lower part of the ureter, which we call strain squaze. In that case, patients may need intervention. URS, short for Euroscopy. It's one of the most common way of dealing with the ureteric stones these days. So what we do is pass a camera through the water pipe into the bladder and through there into the ureter over a wire, and then we break the stone. There are different modalities of breaking the stone in these patients, and there are different instruments for going into the tube as well. Some are rigid, some are flexible, and they have their names according to whether they are rigid or flexible. But mostly for lower ureter and mid-ureteric stones, and even for upper ureteric stones, sometimes we use rigid ureteroscope, and for upper ureteric stones, ureter stones, and kidney stones, we use flexible ureteroscope. Then the modality of breaking the stones, there are different modalities, and they have their own benefits and pros and cons. Like the pneumatic lithoclast, which is most widely available and is the most cheapest option. It's very good treatment option. It's quicker for stones in the lower ureter, but as the stone goes in the upper ureter or mid ureter, it gets very difficult to break them without pushing them back into the kidney. And so in these cases, we like to do laser lithotripsy, where there is very minimal repropulsion of the stone back into the kidney. Then the other treatment options we can offer to patients is retrograde or antegrade stenting. Again, it's a temporary measure to bypass the obstruction. It's a coiled tube, which is called double J stent or DJ stent short form. It has two coils. One coil sits in the kidney, the other coil sits in the bladder, and it bypasses any obstruction around the ureter or within the ureter. A ureteric stent, it can be done either antegrade, where we do it through a percutaneous route, and the stent then goes from the kidney into the bladder, or we do it through a retrograde route, where the stent goes from the bladder into the kidney. The good thing about antegrade stenting is that can be done in the local anesthesia, but the retrograde stenting often requires general anesthesia. So other management option that's most commonly used these days for renal stones and very large upper ureteric stones, and is percutaneous nephrolectomy. Here we make a track from the back of the flank and sometimes below the 12th rib, at level of 12th rib, sometimes above 12th rib, depending on which part of the kidney we aim to go into, and we are then able to break the stone. Again, there are different modalities. There is ultrasonic lithotripter, there is pneumatic lithoclasts, and then there is laser. And now there is new technologies that's coming in, which has combined the ultrasound as well as the ultrasonic devices together to achieve better and faster stone fragmentation. Sorry. The PCNL, as I described, is done to flank and requires general anesthesia. The common risks associated with the procedure is sepsis, hemorrhage, and extravasation of urine through ruptured phylactery system. If a patient develops sepsis, there's a very high mortality from sepsis developed from PCNL. But overall, the rate is very low of patients developing infection, and it's quite safe and effective procedure. Open stone surgery is almost non-existent now because of the increased morbidity and availability of less invasive alternative procedures. In patients who have a very, very large stone burden and have marked thinning of the parenchyma, we may do a partial nephrectomy, or if the stones, if the kidney doesn't have any function and patient has some symptoms related to kidney, then we can remove that kidney. Thank you.
Right, thank you very much, Dr. Hafiz. That was a really useful presentation. Would anyone like to pop any questions in the chat box? I'll just give you guys a couple of minutes in case anyone wants to ask anything. So, Dr. Hafiz, someone has asked if you could please go back to the slide on renal colic pain radiation, please.
This one. We explained that the stone's location can be predicted from the radiation of the pain. So patients with flank pain and have renal or urinary colic, if their pain is radiating to testicles or groin, and they're most likely to have upper uretaric stones. And I believe most of you have seen patients who present with flank pain radiating to groin as presenting complaint of the patients. And then on the later imaging, you find out that these patients have an upper uretaric or PUJ stone. And the cause is because they have because the pain reduced the testes, and the testes have the same nerve supply as the upper ureter. So that's why the pain from the upper ureter reduced the groin or testes. And then mid-ureteric stones refer to the McBurney's point, and it's simulate pain of appendicitis on the right side, and if the stone is on the left side, it may be confused with diverticulitis or constipation. Then lower ureteric stones, in which there is a very high chance that patients will be able to pass the stones spontaneously. There are symptoms of vesical irritability. Patients often present with an associated symptoms of frequency, urgency, and other lower urinary tract symptoms. And in men, patients may complain of pain in the urethra and sometimes tip of the penis.
Great, that's fine. And there was just one more question. Dean has asked, what is the use of taking a plain X-ray after CT-KUB?
Yeah, so this is often, this is a very good question. It's often asked by me, by the junior doctors. So the rationale of doing an X-ray after CT-KUB is to assess whether the stone is radio-opaque or radiolucent. So as we discussed that some of the stones are radio-opaque, all of the calcium-containing stones are radio-opaque, and non-calcium stones like cysteine stones or uric acid stones, they are radiolucent. So when we are planning to give different treatments to patients, we want to know whether the patient can have X-ray based treatment options like lithotripsy. So if we are thinking that we might offer patient lithotripsy, where we guide the shock waves of the lithotripsy machine using X-ray technology, we need to make sure that the stone is visible on the X-ray, plain X-ray film. So that's why we do X-ray KUB in patients with CT KUB. And then again, even if we are not planning to give patients lithotripsy option, the other rationale of doing an X-ray KUB is to monitor the stone, because CT KUB is a lot of radiation, and sometimes stones of mid-ureter or upper ureter are not really good visibility, have good visibility on the ultrasound scan. They often get missed. So if they're visible on the X-ray, we can just monitor the patient on a follow-up X-ray after 4 to 5 weeks of giving them either conservative management or giving them MET therapy, and follow up with just an X-ray KUB, and that avoids lots of radiation from CT KUB.
Perfect. Thank you very much, Dr. Hafiz. I don't think at the moment we have any more questions, so if we could just move to the very last slide, if that's okay. So yeah, thank you again for everyone for joining us again for one of our sessions. If we could just keep that last slide open, feel free to go ahead and use the QR code just on the screen now. You can use that for feedback and get yourself a certificate. If you happen to remember any of the questions later on, do send us an email on the address provided, and we'll be happy to answer those questions in due course. And please make sure to join us next time. Our next session is going to be about lower urinary tract symptoms and benign prostatic hyperplasia. So thank you all again, and have a happy festive period, and I'll see you next week. Thank you very much.
Thank you.